Hello everyone, I am myself Dr. 𝗑𝐲𝐫𝐢𝐛𝐞. I am the general medicine educator. So in this particular section, I'll be discussing the nephrology in a very concise and crisp manner. The topics that I'll be discussing will be urine analysis, acute kidney injury, chronic kidney disease, renal replacement therapy. Following that, I'll be discussing the nephrotic syndrome and as well as nephritic syndrome, then polycystic kidney disease and renal tubular acidosis. So these are the topics I'll be discussing in this particular section. So the first important topic will be the urine analysis. So in the urine analysis, what all we need to check for? In the urine analysis, we need to check for the presence of cells, presence of the proteins, presence of the RBC, any other abnormal constituents like cast. So these are the various abnormalities that we need to check for, and in the urine analysis you also need to check for the pH and as well as the specific gravity of the urine. So first, very important, let me discuss about the proteinuria. So if you take the proteins in our body, the major protein in our body will be albumin, and apart from that we have globulin, fibrinogen, and many other proteins are being present within the plasma. So if you take the normal total proteinuria, the normal total proteinuria, it is around 150 milligrams per 24 hours, right? Less than 150 milligrams per 24 hours. And in this less than 150 milligrams per 24 hours, like how much is the quantity of the albumin which is excreting out normally? Normal albuminuria, it is less than 30 milligrams per 24 hours. Then what is that remaining 120 milligrams? That remaining 120 milligrams, it is the TAM horsefall protein. The word THP stands for TAM horsefall protein. This particular TAM horsefall protein, it is secreted by the renal tubules, and the TAM horsefall protein which is secreted by the renal tubules is what is contributing to the remaining 120 of 150 milligrams per 24 hours. Now, if you take these proteins, the proteins can be tested by the dipstick test, but the point is this particular dipstick test can only detect the negatively charged proteins, that is albumin. And how much is the normal quantity of the albuminuria? The normal quantity of the albuminuria, it is less than 30 milligrams per gram of creatinine. What is this milligram per gram of creatinine? See, in this 24-hour urine collection, there can be false samples. There can be under collection or there can be over collection of the sample. Now, in order to avoid this under collection or over collection, what is that we can do is the urine spot albumin levels or urine spot protein levels. So in this urine spot protein or albumin level, what we can do is milligram per gram of the creatinine can be tested. So the normal albumin is less than 30 milligram per gram of the creatinine. And you take the positively charged proteins that can be present abnormally within the urine analysis is the light chains, which are present in case of the multiple myeloma. But the point that you need to understand is the dipstick test cannot detect the positively charged proteins. That is the reason why in case of the multiple myeloma, the dipstick test will be false negative, right? False negative. Okay. Now, coming to the terminologies, moderately and as well as severely increased albuminuria and the overload proteinuria. Now, what do you understand by this term moderately increased albuminuria? Moderately increased albuminuria is the quantity of albumin that is being excreted out is around 30 to 300 milligram per gram of creatinine. That is moderately increased albuminuria. Then when do we use this terminology? Severely increased albuminuria. Severely increased albuminuria is that where the albumin is excreted out in a range of 300 milligrams to 3500 milligrams per gram of the creatinine. That is the moderately increased albuminuria. Whereas overload proteinuria, if you take the quantity of the protein that is being excreted out is more than 300 milligram per gram of creatinine. Now, what are the conditions where you will have moderately increased albuminuria? And please remember, the presence of moderately increased albuminuria or presence of severely increased albuminuria, the individual is at increased risk of the cardiovascular mortality, right? The individual is at increased risk of cardiovascular mortality. Now, This moderately increased albuminuria, it is also called as microalbuminuria previously, but the present terminology is moderately increased albuminuria. Now, what are the conditions where you will have moderately increased albuminuria is, it is observed in case of diabetes mellitus causing diabetic nephropathy. It is also observed in hypertension, and it is also observed in conditions like glomerulonephritis. These are the three conditions where you will have moderately increased albuminuria. Whereas severely increased albuminuria, where the quantity of the albumin that is excreted out is in a range of 300 to 350 milligram per gram of the creatinine. So what are the conditions? And this severely increased albuminuria, previously it was called as the macroalbuminuria. What are the conditions? Apart from these three conditions, that is diabetic nephropathy, hypertension, glomerulonephritis, they will also progress to severely increased albuminuria. Apart from this, you also observe in case of multiple myeloma, you also observe in the scenario of the congestive heart failure, and you also observe in the scenario of the fever. So these are the conditions where you will have severely increased albuminuria. Then coming to overload proteinuria. Overload proteinuria, it is present in case of multiple myeloma, also present in case of rhabdomyolysis, where there is degeneration of the muscle due to crush injury. Next is in cases of the hemoglobinuria, that is observed in case of the hemolytic anemias. So these are the conditions where you will have overload proteinuria. And we have one more terminology called functional proteinuria. Functional proteinuria is observed when the individual is doing exercise or when the individual is jogging. That is when you will have the functional proteinuria. Now coming to nephrotic range proteinuria. So nephrotic range proteinuria is what is nothing but, it comes under overload proteinuria, where the quantity of the proteins that are being excreted out is more than 3500 milligrams per 24 hours, or the quantity of the protein which is excreted out is more than 3500 milligram per gram of creatinine, right? And what are the causes for nephrotic range proteinuria? We'll be discussing. That is mainly diabetes mellitus, minimal change disease, focal segmental glomerulosclerosis, and then membranous glomerulonephritis. Now, how is that you can analyze this particular, the urine protein, that is negatively charged protein, can be detected by the dipstick test. Now, when do we use this term called trace? Right? The term trace, we use it when the quantity of the protein that is excreted is around 15 to 30 milligram per deciliter. Then when do we use this term called 1 plus? 30 to 100 milligram per deciliter. And when do we call 2 plus? We use the term 2 plus when the quantity of the protein which is excreted out is around 100 to 300 milligram per deciliter. And when do we use this term called 3 plus? We use the word 3 plus, that is around 300 to 1 gram per deciliter, right? 300 to 1 gram per deciliter. And when do we use this term 4 plus? We use this term 4 plus when the quantity of the protein which is excreted out is more than 1 gram per deciliter. That is when we use the term called 4 plus. Okay. Then we have two more terminologies called glomerular proteinuria and as well as the tubular proteinuria. Glomerular proteinuria, it results from the leakage of the plasma proteins through the glomerular filtration barrier. Whereas tubular proteinuria, it results from failure of the tubular absorption of low molecular weight plasma proteins. That is what is called tubular proteinuria. Then what is the daily excretion of the glomerular proteinuria? The daily excretion of the glomerular proteinuria, it is more than 3 to 3.5 grams per 24 hours. Okay, so this is when we use the term called glomerular proteinuria. Then when do we use this term called tubular proteinuria? We use the term tubular proteinuria when the quantity of the protein which is excreted out is more than 2 grams per 24 hours. That is when we use the term called tubular proteinuria. And in glomerular proteinuria, the predominant protein that is excreted out is the albumin, whereas in case of the tubular proteinuria, the predominant protein that is excreted out is the small molecular weight proteins, and these small molecular weight proteins are the beta-2 microglobulins. That is what is being excreted out in case of the tubular proteinuria. Next, now So this is about the proteinuria. Then you need to be completely aware of the caste. Please remember, when we are using this particular term called caste, caste is always formed in the kidney, right? And how is it formed? It is formed by the precipitation of the 𝗂 protein with abnormal constituents like RBC, WBC, or certain pigments or certain crystals. And this particular caste, it is formed exactly at the distal convoluted tubule, right? It is formed at the distal convoluted tubule. And if you are having the presence of caste in the urine, that tells that the pathology is within the kidney itself. Now we have various types of caste depending upon what are the abnormal constituents precipitating with the 𝗂 protein. For example, if the RBCs are precipitating with 𝗂 protein, that we call it as RBC caste, and you observe that in case of glomerulonephritis. And not only glomerulonephritis, you also notice that in cases of vasculitis as well. Now what is that particular vasculitis where you will have the RBC caste is the 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 purpura, right? Next, coming to the WBC caste. The WBC caste, it is observed in case of the pyelonephritis, and WBC caste is also observed in cases of the glomerulonephritis. So these are the scenarios where you have the presence of the WBC caste. Then followed by that, okay, now you just see this image, very important image. Now whenever we collect a urine sample, there is a chance that there can be presence of the foam in the urine sample. Now the foam which is there over the urine sample, when do we consider this has to be a normal foam, or when do we consider this particular foamy urine because of the proteinuria? Now if suppose after placing the sample for at least 5 minutes, if the foam is cleared, right, if the foam is cleared after 5 minutes of placing the sample, then we consider it to be the normal urine sample. Whereas if suppose if there is presence of the foam even after 15 minutes after collection of the urine sample, this we consider it as proteinuria, right? This we consider it as the proteinuria, right? Now, so this is what is nothing but your how to differentiate the foamy urine to be a normal sample or the proteinuria, right? Now, let me just continue with the caste again. So, RBC caste in glomerulonephritis, WBC caste in pyelonephritis. Now, what are the conditions where you will have the pigment caste? The pigment caste, the pigment or granular caste is observed in case of myoglobinuria or the hemoglobinuria. Then eosinophiluria, where the eosinophils will start getting excreted within the urine, and that is observed in case of allergic interstitial nephritis, and it is also observed in case of atherosclerotic diseases causing acute kidney injury. You will have the eosinophiluria. What are the conditions where you will have crystalluria is, you observe that in case of acute uric acid nephropathy, that is in case of gout or gouty arthritis, and as well as the calcium oxalate crystals. These are the two scenarios where you will have the presence of the crystalluria, right? So this is about the caste. The next important part of the discussion is about the RBC. Now, the RBCs within the urine sample can be in two forms. One is the individual RBCs, or there can be presence of the RBC caste. Now, you take the low power field microscopy. Low power field microscopy, it is useful for examining the caste. Whereas, if you take the high power field microscopy, the high power field microscopy, it is useful for detecting the RBCs, WBCs, and as well as bacteria. That is the high power field. Whereas low power field, it is for detecting the presence of the RBC caste. Now, how many number of RBCs can be there in a normal individual? In a normal urine sample, the number of RBCs that can be there is 0 to 3 RBCs per high power field. And the number of RBC caste that can be there within the urine sample, it is 0. There should not be any RBC caste within the urine sample, right? Then, coming to when do we call this terminology microscopic hematuria? We use the term microscopic hematuria if the number of RBCs are more than or equal to 3 per high power field, right? And this particular microscopic hematuria, please remember, it should be there on 2 out of 3 properly collected urine analysis specimens. You need to collect 3 samples. Out of these 3 samples, in the 2 samples, there should be more than or equal to 3 RBCs per high power field. Then, when do we use this term called significant or the persistent hematuria? Significant or persistent hematuria, we use this term when the number of RBCs are more than 5 RBCs per high power field. Right? When there are more than 5 RBCs per high power field, then we consider it as significant or persistent hematuria. And this more than or equal to more than 5 RBCs per high power field, that should be there in per around 3 times. Right? It should be there for around 3 times in an interval of 3 weeks. Right? In an interval of 3 weeks. That is what we use the term called significant or persistent hematuria. That means one sample you are collecting this week, next sample the other week, the next sample on the 3rd week. So in all these 3 specimens, there should be more than or equal to 5 RBCs per high power field. Or in a single sample, if there are more than 100 RBCs per high power field, then also we use the term called significant or persistent hematuria, right? Then coming to the dysmorphic RBC. Dysmorphic RBCs is nothing but where the RBCs, they have the odd shape. The normal shape of the RBC is biconcave. Dysmorphic RBCs are nothing but the odd shaped RBCs, and that is due to passage of the RBCs through abnormal glomerulus. Right? Passage of the RBCs through the abnormal glomerulus. Okay, that means your dysmorphic RBCs tells you that there is abnormal glomerular structure. Okay, and this dysmorphic RBCs tells you it's a glomerular bleed. Right? Next, what are the causes for the red urine? See, there are certain substances which will give the red color to the urine. Number 1, the drugs like clofazimine and as well as porphyrins, they cause the red urine. Right? Next, if there is hematuria, pyuria or bacteriuria, it is suggestive of the urinary tract infection. And if there is presence of the oval fat bodies, what is it suggestive of? The presence of the oval fat bodies, it is suggestive that there is lipiduria, and it is observed in case of the nephrotic syndrome. Right? Observed in case of the nephrotic syndrome. Right? Then next is presence of the Maltese cross appearance crystals within the urine. So the conditions where you will have Maltese cross appearance crystals in the urine is, it is observed in case of nephrotic syndrome, and it is also observed in one of the genetic abnormality, that is Fabry's disease. Fabry's disease is that where you have a gene mutation, that is GLA, and the enzyme that is being deficient is alpha galactosidase deficiency. Right? Alpha galactosidase deficiency. Then the peripheral smear having the Maltese cross appearance is in case of Babesia microtype, you will have Maltese cross appearance. Right? And CSF analysis showing Maltese cross appearance is, it is observed in cases of cryptococcal meningitis, you will have the Maltese cross appearance in the CSF analysis. So this is about the Maltese cross appearance in the urine sample. And in the urine analysis, the next important thing that you need to know is about the specific gravity of the urine. Normal specific gravity of the urine, it is around 1.020 to 1.030, and the normal urine osmolality is around 100 to 900 milliosmoles. There are multiple conditions where the urine osmolality can be reduced. Urine osmolality can be reduced in conditions like diabetes insipidus. Urine osmolality can be reduced in conditions like psychogenic polydipsia, whereas urine osmolality is increased in case of diabetes mellitus because of glucosuria. So that is about the specific gravity. Next, what do you understand by this word isosthenuria? The word isosthenuria means inability to concentrate the urine. That is what you mean by the term the isosthenuria. Right? Where the individual is excreting the urine whose specific gravity is neither greater nor lesser than that of the protein-free plasma. So the specific gravity of the urine sample is equivalent to specific gravity of the plasma, right? And how much will be that? That will be around 1 point, right? That will be around 1.0 0.008 to 1.012. That is the specific gravity of the plasma. The same will be the specific gravity of the urine. That is what we use the term called isosthenuria. Now, the conditions where you will have isosthenuria is in cases of tubulointerstitial diseases, in conditions like the sickle cell disease. These are the two scenarios where you will have the isosthenuria, right? Chronic tubulointerstitial disease and sickle cell disease. Next, you need to know that pH of the urine is another important thing that we need to discuss. What is the normal pH of the urine? Normal pH of the urine is 4.5 to 8. The conditions where the pH of the urine will change is mainly in renal tubular acidosis. In case of type 1 and as well as type 4 renal tubular acidosis, the urine pH will be more than 5.5. Whereas in type 2 renal tubular acidosis, the urine pH, it is less than 5.5, right? So that is about the urine pH. Next, you need to be completely aware of the color of the urine. So what are the conditions where you will have the pink urine is whenever the individual is consuming desferoxamine, which is an iron chelating agent that can give rise to a pink urine. And the pink diaper sign is caused by the infections caused by the Serratia marcescens. And the conditions where you will have red urine is clofazimine or porphyria or the myoglobinuria. And cola colored urine is observed in case of the hematuria or glomerulonephritis. Black color urine is observed in case of the hemoglobinuria, right? That hemoglobinuria you will have in case of paroxysmal nocturnal hemoglobinuria and paroxysmal cold hemoglobinuria. And the conditions where the urine will turn into black in color on exposure to air, that you will observe in case of the alkaptonuria. So this is about the urine analysis, right? Wherein I discussed about the proteinuria, hematuria, caste, pH, specific gravity, and as well as the abnormal colors of the urine. So the next topic for the quick discussion is the acute kidney injury. So acute kidney injury, the definition is given by the KDIGO guidelines. And according to the KDIGO guidelines, there are two important parameters which will decide the definition. One is the serum creatinine and the other one is the urine output. So serum creatinine, it should be increased by more than 0.3 milligrams per deciliter within 48 hours, right? Or there should be increase in serum creatinine more than or equal to 1.5 times the baseline in 1 week, right? In 1 week. That is one part of the criteria or one part of the definition. And the urine output should be decreased. And how much is that urine output should be decreased is less than 0.5 ml per kg per hour for more than 6 hours, right? That is what is the decrease in the urine output according to the KDIGO guidelines. So these are the two things that are there within the KDIGO guidelines for defining acute kidney injury. And we have one more important definition, that is acute kidney injury network criteria. So in this acute kidney injury network criteria, what has been included is staging has been included. Stage 1, 2, 3, depending upon the severity of increase in serum creatinine and as well as depending upon the severity of decrease in the urine output. Now, if you take the etiology of the acute kidney injury, the etiology of acute kidney injury, we classify that into the pre-renal, then we have intrinsic renal, then we have the post-renal, right? Pre-renal, intrinsic renal and post-renal. Now, what do you understand by the word pre-renal? The word pre-renal mean the perfusion to the kidney is reduced. Normally, the kidney will receive 20% of the cardiac output. So any condition which is decreasing the intravascular volume, right? Any condition which is decreasing the intravascular volume will decrease the renal perfusion, and that will result in the pre-renal type of the acute kidney injury. Now, what are those conditions? Decrease in intravascular volume is observed in case of gastroenteritis and as well as severe vomiting. These are the two conditions, and the individual on the diuretics in increased quantity. There can be decrease in the intravascular volume, right? Next, decrease in cardiac output is observed in conditions like the congestive heart failure. Renal vasoconstriction will cause decreased renal perfusion, and that can be observed in case of the hypercalcemia and as well as the sepsis. And impaired autoregulation is caused by certain drugs which will affect the renal perfusion, and these drugs include the NSAIDs and as well as the AC inhibitors. And these NSAIDs will cause the afferent arteriolar constriction, causing decrease in renal perfusion, whereas AC inhibitors or ARBs will cause the efferent arteriolar dilatation, causing decreased renal perfusion. Then the second important etiology causing acute kidney injury will be intrinsic renal, and these large vessel diseases which will be causing intrinsic renal will be Takayasu arthritis, right? Takayasu arthritis. And glomerular diseases that will be causing intrinsic renal will be glomerulonephritis and then hemolytic uremic syndrome. Acute tubular necrosis, this is caused by ischemia, and this we call it as the ischemic acute tubular necrosis. And the other condition where you will have this acute tubular necrosis, right, it is observed by the toxins. And these particular toxins, that includes endogenous toxins, and these toxins, it includes the exogenous toxins. Then what are these endogenous toxins? These endogenous toxins include like light chains in case of multiple myeloma, they accumulate in the tubule causing acute tubular necrosis, right? Next, in case of hemoglobinuria observed in case of the hemolytic anemia. Next, in case of myoglobinuria observed in case of the Crush syndrome. Then in case of tumor lysis syndrome, where there is excessive uric acid accumulation within the tubule causing acute tubular necrosis. Then exogenous toxins are mainly the drugs, and these drugs include number one, the contrast material used in the treatment of contrast material used for the diagnostic purposes, that is contrast induced nephropathy. Then we have many antibiotics like amphotericin B, then aminoglycosides, antiviral drugs like tenofovir, then the drugs used in the treatment of osteoporosis, that is bisphosphonates, then the antibiotics like cephaloridin, next colistin. These are the exogenous toxins which can cause acute tubular necrosis. Then what are the interstitial diseases? Okay, so the interstitial diseases that will be causing intrinsic renal will be, that includes leptospirosis, which is caused by an infectious agent, then NSAIDs, non-steroidal anti-inflammatory drugs. These are the interstitial diseases that will be causing intrinsic type of acute kidney injury. Now, coming to contrast-induced nephropathy, this is very common in diabetic patients. And in contrast-induced nephropathy, by almost 24 to 48 hours, that is by 2 days, the serum creatinine, it slowly start increasing. Okay, and by almost 2 to 5 days, the serum creatinine will start peaking by 2 to 5 days, and by almost 5 to 7 days, the serum creatinine will return back to normal. That is what you observe in case of contrast-induced nephropathy. And what is the treatment for contrast-induced nephropathy is, you need to give IV fluids, and the drug of choice will be N-acetylcysteine, right? Next, coming to tumor lysis syndrome. The most common tumor that will be responsible for tumor lysis syndrome will be the Burkitt's lymphoma. And what are the electrolyte abnormalities that you will notice in case of tumor lysis syndrome is, there will be hyperkalemia, there will be hyperphosphatemia, increase in the uric acid levels, and there will be decrease in the calcium levels, because the calcium will combine with increased phosphate, resulting in calcium phosphate. So this will be the electrolyte abnormalities, and the treatment that you will give in case of the tumor lysis syndrome, the drug of choice will be rasburicase. So what is this rasburicase? Rasburicase is the one which will break the uric acid into allantoin, and allantoin is excreted out. So it is not like directly uricosuric agent. It will break the uric acid into allantoin, and allantoin gets excreted out. That is how the mechanism of the action of the rasburicase will be, and that is the drug of choice. And you also need to give the drugs which will reduce the uric acid synthesis, where you need to give allopurinol. So allopurinol is a xanthine oxidase inhibitor, and the other important drug is febuxostat. Next is, that was about tumor lysis syndrome. Next is ethylene glycol intoxication. See, ethylene glycol, it is used as an antifreeze, and in case of ethylene glycol intoxication, there will be formation of the calcium oxalate crystals, right? There will be formation of the calcium oxalate crystals, and these patients will land up in acute kidney injury, and that too intrinsic type of acute kidney injury and exogenous toxin. And the antidote for ethylene glycol intoxication will be fomepizole, right? It may be fomepizole, that is the antidote. Now coming to the atheroembolic disease. So if you take this atheroembolic diseases, these atheroembolic diseases also are the one which will cause intrinsic type of acute kidney injury, and this is secondary to the catheterization. Whenever you are passing the catheter through femoral artery, and the atherosclerotic plaque which is there within the aorta, if it is hit by the catheter, the plaque can get ruptured, and the plaque will be entering into the circulation in the form of emboli. And if this particular emboli enters into the kidney, that can initiate the allergic reaction, and where these patients will have eosinophiluria. Right, these patients will have the eosinophiluria. That is what you will notice in case of the atheroembolic disease, right? And not only eosinophiluria, there will be also increase in the eosinophil levels as well. Then what is the cutaneous manifestation? The cutaneous manifestation in these patients will be like net-like formation of the blood vessels over the skin, and that is called livedo reticularis. And the retinal changes is that these particular plaques can enter into the retinal vessels, and you have the presence of the Hollenhorst plaques. And this particular Hollenhorst plaques, they are one of the very important feature in case of the atheroembolic disease. And the blood picture, the eosinophil levels will be increased. Eosinophil levels will be increased, and you need to treat this particular acute kidney injury depending upon whatever the electrolyte abnormalities or whatever the metabolic abnormalities that the patient have developed. Okay, now following that, you need to differentiate the pre-renal from intrinsic renal. One of the very important parameter that will differentiate pre-renal from intrinsic renal will be your fraction excretion of sodium. So fraction excretion of sodium in case of pre-renal, it will be less than 1, whereas in intrinsic renal it will be more than 1. And urinary sodium concentration in pre-renal will be less, whereas in intrinsic renal it will be more than 20 milliequivalents. Urine osmolality also, if you observe, the urine osmolality in case of pre-renal will be more, that is more than 500 milliosmoles, whereas in intrinsic renal it is around 350 milliosmoles. Then coming to the renal failure index in case of pre-renal will be less than 1, whereas in intrinsic renal it will be more than 1. And blood urea nitrogen to the creatinine ratio, it will be more than 20 in case of pre-renal, less than 10 to 15 in case of the intrinsic renal. And the urine sediment will show you the presence of the hyaline cast in pre-renal, whereas in intrinsic renal you have the presence of muddy brown granular cast. And the urine specific gravity in case of pre-renal will be more than 1.020, whereas in intrinsic renal it is around 1.010. That is what you observe in case of intrinsic type of acute kidney injury. So these are the pre-renal and intrinsic renal. Now what are the post-renal causes? Post-renal causes are those where the pathology is outside the kidney. So it is mainly the obstructive pathologies like the ureteric stones, bladder malignancy, benign prostatic hyperplasia. These are the causes for the post-renal. Or not only that, even bilateral ureteric fibrosis observed in case of the scleroderma. Bilateral ureteric fibrosis caused by methysergite. These are the post-renal causes for acute kidney injury, right? Now, following this etiology, pre-renal, intrinsic renal and post-renal, let me discuss how do you investigate these patients with acute kidney injury. See, if you take the clinical features that you will have in these patients, the clinical features will be due to increase in the nitrogenous waste products, that is increase in urea and as well as creatinine, and the clinical features will be due to decrease in the urine output. So decrease in urine output, these patients will have the fluid overload. And what will be the features of the fluid overload? Hypertension, periorbital edema, pericardial effusion, pleural effusion, ascites, pedal edema, pulmonary edema causing respiratory distress. These will be the features of the fluid overload. There will be also features of increase in urea levels like uremic manifestations. The urea will cross the blood-brain barrier causing uremic encephalopathy, where the patient will present with altered sensorium, seizures. And urea will also accumulate within the pericardium causing uremic pericarditis, where there will be chest pain. And urea will also accumulate in the pleura causing uremic pleuritis. That is also the one which will contribute to the development of the chest pain. And uremic gastroparesis. Uremic gastroparesis is that where these patients can have the constipation. So that is, and the urea can also accumulate within the skin, resulting in xerosis. So these are the manifestations that you will have because of increase in the urea levels, right? Next, coming to the electrolyte abnormalities that you will have in case of acute kidney injury, there are certain electrolytes which are increased. That is hyperkalemia. Next is the hyperphosphatemia, and next is hypermagnesemia. Next is increase in the uric acid levels, right? And following that, even the calcium will be reduced. Why? Because that ionic calcium will combine with phosphate to form calcium phosphate, so ionic calcium level decreases. And the another important substance that will be reduced will be sodium, and this sodium which is being reduced is mainly because of the dilution effect. Okay, next, and this imaging, that is mainly USG abdomen, it is useful for diagnosing the postrenal type of acute kidney injury, that is ureteric alkali, bladder malignancy, benign prostatic hyperplasia, ureteric fibrosis, that will be made out by USG abdomen. Now coming to the treatment, in contrast induced nephropathy, along with IV fluids you need to give N-acetylcysteine, which is a drug of choice. Whereas in case of the tumor lysis syndrome, the drug of choice will be rasburicase, right? Drug of choice will be rasburicase. And mechanism already I have discussed, and the other alternative drug will be allopurinol, which is a xanthine oxidase inhibitor, which will decrease the uric acid synthesis. Rhabdomyolysis, you need to do alkaline diuresis. For volume overload, you need to restrict the fluid overload of the, you need to restrict the fluid intake of the individual. Then you need to give diuretics, and this particular diuretics that you need to give is furosemide. Right, you need to give is furosemide. Next is hyponatremia, and this particular hyponatremia is mainly because of the dilution effect, and because of the hyponatremia these patients have the altered sensorium, they have the development of the seizures. And this particular hyponatremia, how is that you can treat? So you have to treat this hyponatremia by 3% sodium chloride, right? That is when the individual has symptomatic hyponatremia, you need to give 3% sodium chloride, right? And for hypertension, for hypertensive crisis, you need to give labetalol. Okay, then what are the indications for dialysis in patients with acute kidney injury? The indications for dialysis, I have just given you a mnemonic, that is have P. The word H is refractory hyperkalemia, right? Next A, that is acidosis, that is refractory acidosis. V stands for volume overload, that is refractory to your diuretics. Then E stands for elevated blood urea nitrogen, and that elevated blood urea nitrogen, it should be, or it will be more than 35 millimoles per liter. Then next is P. The word P stands for the pericarditis, right? The word P stands for the pericarditis, and E stands for the encephalopathy, right? E stands for encephalopathy, where you need to do dialysis, and the another E stands for edema, and that should be pulmonary edema, right? So these are the indications for dialysis in acute kidney injury. Next, there are certain novel biomarkers in acute kidney injury, and these novel biomarkers in acute kidney injury will be kidney injury molecule 1, that we call it as KIM1, and this kidney injury molecule 1, it is expressed in the proximal convoluted tubule. Then the next important is the NGAL, that is neutrophil gelatinase associated lipocalcin, that is observed in case of the tubular damage. And next is the interleukin 18, and next important is the L-type fatty acid binding protein, right? L-type fatty acid binding protein. So these are the novel biomarkers in case of the acute kidney injury. So this is about the quick discussion related to acute kidney injury. The next topic which I will be taking up for the discussion is chronic kidney disease. So what is the definition of the chronic kidney disease? So the definition of the chronic kidney disease is also given by the KDIGO guidelines, and according to the KDIGO guidelines, there are two parameters which are taken into the definition. Number one, there should be decrease in the GFR, that is glomerular filtration rate. And how much should be that decrease in the GFR? It should be less than 60 ml per minute per 1.73 meter square. That is the decrease in the GFR. And along with decrease in the GFR, there should also be proteinuria, right? And this proteinuria, it should be there for more than 3 months. So decrease in GFR less than 60 ml per minute per 1.73 meter square along with proteinuria, that should be there for more than 3 months. That is what is your chronic kidney disease according to the 𝐤𝐫𝐢 guidelines. And you take the GFR. How much is the normal GFR? Normal GFR is 90 to 120 ml per minute per 1.73 meter square. And depending upon the decrease in the GFR, like we have the 5 stages of chronic kidney disease. So you take in case of stage 1. In stage 1, the GFR is more than 90 ml per minute per 1.73 meter square. And in stage 2, you reduce the GFR by 30. So that will be around 60 to 89 ml per minute per 1.73 meter square. Then stage 3, this will be 30 to 59 ml per minute per 1.73 meter square. And stage 4, this will be around 15 to 29 ml per minute per 1.73 meter square. Then stage 5 is considered as end-stage renal disease where the GFR is less than 15 ml per minute per 1.73 meter square. And this stage 5, right? So this is considered as end-stage renal disease, right? This is called as end-stage renal disease. And in end-stage renal disease, like it is advised to start the renal replacement therapy in the form of kidney transplantation or the dialysis. And next is the proteinuria, and the protein which is predominantly taken in the staging is the albuminuria, that is A1. So A1 is less than 30 milligram per gram of creatinine. A2 is 30 to 300 milligram per gram of creatinine. And A3, it is more than 300 milligram per gram of creatinine. So that is what is your albuminuria, that is A1, A2 and as well as A3. Alright. And the very important part of the discussion is the clinical manifestations. So you will have the clinical manifestations due to fluid overload, and that clinical manifestations due to fluid overload will be in the form of the periorbital edema, that is number 1. And number 2, these patients will have the pericardial effusion, right? They will have pericardial effusion. Then these patients will also develop the pleural effusion, and these patients will also develop the ascites, and these patients will also develop the pedal edema, and these patients will also develop pulmonary edema resulting in respiratory distress. So these will be the features of the fluid overload. Then due to increase in urea and as well as creatinine. So due to increase in urea and creatinine, these patients, urea will cross the blood-brain barrier and will go and accumulate within the brain, resulting in the uremic encephalopathy, right? Resulting in uremic encephalopathy. And urea will also accumulate in the pericardium, resulting in the uremic pericarditis. And because of the uremic pericarditis, they will have chest pain, and then urea will also accumulate in the pleura, resulting in the uremic pleuritis, and due to which there will be chest pain, that to a pleuritic type of chest pain. That means where there will be increase in the pain on inspiration, and it will be a pointed pain. And next is uremic gastroparesis, where these patients will present in the form of constipation or in the form of diarrhea. Either of it there can be. And the urea will also accumulate within the cornea, resulting in band keratopathy. Then urea will also accumulate within the skin, resulting in dryness of the skin or xerosis, where there will be excessive pruritus. And urea will also accumulate in the peripheral nerves, resulting in the peripheral neuropathy. And urea will also accumulate within the genitourinary system, and that will result in the development of impotency. So these are the uremic manifestations that you have in patients with chronic renal failure. Then you take the metabolic abnormalities. Metabolic abnormalities that you will have is, there is high chances of hypoglycemia in diabetic patients who are taking insulin with chronic renal failure. Why? Because insulin has to be excreted through the kidney. So once there is renal failure, the half-life of the insulin increases, and that will reduce the glucose levels, and that will result in the hypoglycemia. And in chronic renal failure, there is also decrease in lipoprotein lipase activity, and because of decrease in lipoprotein lipase activity, there will be dyslipidemia. So there will be increase in the lipids, right? And the blood picture, if you take, because of erythropoietin deficiency, these patients will have anemia, and the type of anemia will be normocytic normochromic type of anemia. And not only that, the reason for anemia is also because of accumulation of the urea within the bone marrow, resulting in bone marrow fibrosis, resulting in anemia. And even the function of the granulocytes will be reduced, right? The function of the WBCs will be reduced. Because the function of the WBCs or granulocytes are being reduced, these individuals, they are at increased risk of the infections. And right, these individuals, they are at increased risk of the infections. And the another very important point is the effect on the platelets. So even the platelet function will get reduced, and thereby these patients will have increased bleeding tendency. Right, these patients will have increased bleeding tendency, wherein these patients will have ecchymosis, wherein these patients will have the excoriation, right, or these patients will have petechiae. So these will be the manifestations because of the thrombocytopenia or decrease in the platelet activity. And the next important that you need to be completely aware of is the etiology. So if you take the etiology, the most common cause for the chronic kidney disease will be diabetes mellitus, and followed by that the glomerular diseases, that is glomerulonephritis, tubulointerstitial pathologies, that is chronic tubulointerstitial nephritis, right, chronic tubulointerstitial nephritis. And cystic diseases include polycystic kidney disease, and obstructive nephropathies include benign prostatic hyperplasia. Actually, benign prostatic hyperplasia will cause postrenal type of acute kidney injury, but the same benign prostatic hyperplasia, if it is being neglected for a prolonged period of time, the acute can turn into a chronic kidney disease. And vascular diseases that will be causing chronic kidney disease will be the renal artery stenosis. Okay, and the electrolyte abnormalities that you have in patients with chronic kidney disease is there will be hyperkalemia, hypermagnesemia, hyperphosphatemia, and there will be dilutional hyponatremia. Calcium levels will be reduced due to two reasons. Number one, vitamin D is not synthesized, so thereby calcium absorption across the intestine will not be there. And this increased phosphate will combine with calcium, resulting in calcium phosphate. So ionic calcium level decreases. And ABG will show you that there is metabolic acidosis. And the reason for metabolic acidosis is, number one, due to decreased excretion of ammonia. Actually, if ammonia gets excreted out, ammonia will take the H plus ion, and ammonia will combine with H plus, where ammonium will be formed and ammonium is excreted out. Now here, because of the chronic kidney disease, ammonia is not excreted out. So thereby the H plus ion is not excreted out, resulting in acidosis. And not only that, in patients with chronic kidney disease or acute kidney injury, there will be increased bicarbonate excretion that also will result in the development of metabolic acidosis. And the bicarbonate levels will be reduced because of increased bicarbonate excretion, and that will be responsible for acidosis. And hyperkalemia, it is one of the dangerous electrolyte abnormality in patients with chronic kidney disease. And this hyperkalemia will cause bradyarrhythmias, resulting in complete heart block, and cardiac arrest can be there. Now, what is the drug of choice in patients with chronic kidney disease? The drug of choice in case of chronic kidney disease will be calcium gluconate. And calcium gluconate, in fact, it will not reduce the potassium level, but it will sensitize or it will stabilize the myocardial membrane to prevent the development of the arrhythmias. And next is insulin plus dextrose. Now, insulin plus dextrose is the one which will cause a quick reduction in the potassium levels, which will shift the potassium from extracellular compartment to the intracellular compartment. Next is furosemide, will cause kaliuria, and even that will reduce the potassium levels. Next is beta agonist. Beta agonists are also the one which will shift the potassium from extracellular to the intracellular compartment. Even that will cause decrease in the potassium levels. Then we have potassium binders. What are the examples of these potassium binders are? These potassium binders, they include sodium polystyrene sulfonate. They bind the potassium within the intestine, and it will decrease the excretion of potassium from the intestine. But the problem with this sodium polystyrene sulfonate is it can cause intestinal necrosis, right? It can cause intestinal necrosis. And the another important example of the potassium binders are, we have the sodium zirconate, right? Sodium zirconate. Right, and the other important drug will be patiromer acetate. right? Patiromer acetate. So these are the potassium binders. Then followed by that, hemodialysis you have to do in refractory scenarios. When the patient is not responding to the medical management, then you need to do hemodialysis and take out the potassium. And what are the drugs which will reduce the phosphate levels? That is aluminium hydroxide, then we have calcium acetate, right, and calcium acetate. So these are the drugs which will act as the phosphate binders. And one more important drug is sevelamer hydrochloride, right, sevelamer hydrochloride. So these are the phosphate binders. And always remember, you need to give calcium supplementation, that is your calcium carbonate or calcium gluconate for hypocalcemia. But before treating hypocalcemia, you need to correct the hyperphosphatemia first. So why there is hyperphosphatemia, hyperkalemia and hypermagnesemia is because of chronic kidney disease. These electrolytes are not excreted out, which have to be excreted by the kidney. And you need to give calcium supplementation only after correcting the hyperphosphatemia, without which if you give calcium keeps on binding with the increase in phosphate, resulting in calcium phosphate, so ionic calcium level decreases. Next, hypermagnesemia, you need to give IV fluids, that is the normal saline, and along with that you can give diuretics which will flush out the magnesium. That is what is the treatment for hypermagnesemia. Now, the most common cause for chronic kidney disease is diabetes mellitus. So you need to give insulin. But the insulin you should give only 80% of the calculated dose, because the insulin half-life increases in chronic renal failure. There is increased chance of the hypoglycemia. And for hypertension, it is preferable to give labetalol. But if the serum creatinine is not increased more than 2 milligrams per deciliter, then you can give ACE inhibitors. The ACE inhibitors, the advantage is they will also reduce the proteinuria, and it will be very much helpful to prevent the development of diabetic nephropathy. But again, whenever you are giving these ACE inhibitors, you need to monitor for potassium, because ACE inhibitors will reduce the aldosterone secretion, and once aldosterone secretion decreases, the potassium excretion does not occur, and that will result in hyperkalemia. So that is the reason why whenever you are giving ACE inhibitors, you need to monitor the potassium. And if the serum creatinine is like more than 2 milligrams percentage, or if there is hyperkalemia, you cannot give ACE inhibitors. For hypertension, what you need to give is labetalol. Then next is dyslipidemia. So there is decrease in lipoprotein lipase activity, and because of which there is dyslipidemia. So these patients, they have to be started on the statins, right? And there is low vitamin D3 levels, because once the kidney is damaged, there is no synthesis of 1-alpha hydroxylase in the proximal convoluted tubule, so vitamin D is not synthesized. So you need to give oral vitamin D supplements. Okay. Next is secondary hyperparathyroidism. So because of the hypocalcemia, there is increase in parathormone secretion, and that increased parathormone will cause the bone resorption, and that will result in the renal osteodystrophy. Right? That will result in the renal osteodystrophy. So this renal osteodystrophy, where the individual will have severe bone pain, and where the individuals will have the pathological fractures, right? So then what is it you need to give for secondary hyperparathyroidism is, you need to give calcium supplementation. This particular calcium supplementation will correct the hypocalcemia, and thereby secondary hyperparathyroidism can be corrected. So this is the medical management that you will be giving in patients with the chronic renal failure. Now, when the individual goes into a stage of the end-stage renal disease, that is the point when you need to give the renal replacement therapy. And the renal replacement therapy can be in two forms. One is dialysis, that is hemodialysis or peritoneal dialysis, and the other one is the kidney transplantation. Right? The other one is kidney transplantation. Now, you take the principle in case of the hemodialysis. The principle in the hemodialysis is by the process of diffusion, where the impurities, they get filtered from the blood across the semi-permeable membrane into the dialysate, and followed by that, so after the process of diffusion, you also need to take out the excess amount of water which is present in the body, and that we call it as the ultrafiltration. So diffusion followed by ultrafiltration. And whenever you are doing hemodialysis, you need to create an AV fistula, and this particular fistula, it is created between the radial artery and as well as the cephalic vein, and the name of this fistula, it is Seminobrevia fistula. Right? It is called Seminobrevia fistula. And what is the most common complication of the hemodialysis? The most common complication of the hemodialysis will be the hypotension, because excess amount of the fluids are being taken out and sent into the dialyzing machine, and that can result in the development of the hypotension. All right. And next to this particular hypotension, the other complications of hemodialysis is that during this process of dialysis, certain vitamins are being filtered out because they are very small. Example, the pantothenic acid is being filtered out, and that will result in the development of the burning feet syndrome, right? That will result in the burning feet syndrome. Okay. And there are certain proteins which are not filtered across the semi-permeable membrane. What are the proteins which are not filtered across the semi-permeable membrane? Is the amyloid beta 2 protein, and that will accumulate within the flexor retinaculum, resulting in the carpal tunnel syndrome. Right. And not only this amyloid beta 2 protein will also accumulate within the brain, resulting in the dialysis dementia. And the other important complication will be, like, these patients will have dialysis disequilibrium syndrome. Now, what do you understand by this word dialysis disequilibrium syndrome is, during dialysis, the osmotic material or nitrogenous waste material are taken out from the body. So, in the brain, the osmolarity of the plasma reduces. The fluid from the plasma will shift into the intracellular compartment, resulting in cerebral edema. That will cause raised intracranial pressure, and because of raised intracranial pressure, these patients will have altered sensorium, projectile vomiting, headache. There can be coma and as well as death as well. So that is what is called dialysis disequilibrium syndrome. Now, coming to the peritoneal dialysis, in the peritoneal dialysis, peritoneum itself will be acting as an artificial membrane, and the dialysate that we use is the dextrose dialysis, right? Dextrose is what is being used as dialysate. And this dextrose solution is sent into the peritoneal cavity, and the peritoneum itself will be acting as a semi-permeable membrane, and the impurities which are there within the blood vessels, that is in the peritoneal blood vessels, they get filtered across the peritoneum into the dextrose-rich dialysate. Now, the impurities which are present in the dextrose-rich dialysate are being taken out. That is what is nothing but your peritoneal dialysis. Okay. And next important is the other way of the renal replacement therapy is by kidney transplantation. So kidney transplantation, the donor and as well as recipient, both of them, they should be having the HLA match, and there should be also matching of the blood grouping. So blood grouping and as well as the HLA, both of them has to be matched. And for HLA matching, the gene is present on the chromosome 9. And for blood grouping, the gene is present on the chromosome 6, right? And very important is which particular kidney of the donor is taken. The left kidney of the donor is being taken because of long renal vasculature for the left kidney, and that is placed in the right iliac fossa of the recipient. And once you place in the right iliac fossa of the recipient, immediately there will be development of rejection, hyperacute, acute or chronic rejection. So hyperacute rejection is that which will occur within minutes of anastomosis. Acute rejection is that which will occur within 6 months of anastomosis. Chronic rejection is that which occur after 6 months of the anastomosis. Right? Chronic rejection is that which will occur after 6 months of anastomosis. So your hyperacute rejection, it's a type 2 hypersensitivity reaction, whereas acute and as well as chronic rejections, they are your type 4 hypersensitivity reactions. Now, in order to prevent the rejections, you need to give the immunosuppressant drugs, and these immunosuppressant drugs are CAP. What does this CAP stands for? Cyclosporin, azathioprine, and then prednisolone. So these are the immunosuppressant drugs which will prevent the rejections, But the problem is, whenever you are giving these immunosuppressants, there is increased chance of the opportunistic infections. And these opportunistic infections which are very common is, number one, the MRSA, that is methicillin resistant Staphylococcus aureus, that is one of the important opportunistic infection. Next to this particular MRSA, then you also have many viral infections like the hepatitis B virus, then polyoma virus, pneumocystis jirovecii pneumonia, aspergillus, that is fungal infection. So these are the opportunistic infections whenever the patient is placed on the immunosuppressant drug, that is cyclosporin, azathioprine and as well as prednisolone. So this is about your quick revision of the chronic kidney disease. Then Next two important topics are nephrotic syndrome and as well as nephritic syndrome. So nephrotic syndrome is that where the individual will have a significant amount of the proteinuria, and the protein that is predominantly excreted out is the albumin. These patients will have renal and as well as the extra-renal manifestation, right? Renal and as well as extra-renal manifestation is what you will observe in patients with the nephrotic syndrome. Now, the proteinuria, if you take the quantity of the proteins which are excreted out, it is more than 3.5 grams per 24 hours, or we describe it as more than 2.5 gram per gram of the creatinine. And the predominant protein that is being excreted out is the albumin. So the albumin level will be less than 2.5 grams per deciliter within the plasma, because if you take the normal albumin level, it is 3.5 to 5 grams per deciliter, and because of the albuminuria, the albumin levels will drop down to less than 2.5. And why predominantly albumin gets out compared to the other proteins is because albumin size is very less. It can easily pass through the glomerulus. But in a normal individual, why the albuminuria will not be there is because of the presence of the 𝐶 which is negatively charged protein on the podocytes, which will repel the protein filtration. But whenever there is glomerulonephritis in nephrotic and nephritic syndrome, the 𝐶 is being lost, and thereby the albumin can get easily filtered from glomerulus to the Bowman's capsule, and it is excreted out within the urine. And because of the proteinuria, the oncotic pressure reduces. Once the oncotic pressure reduces, the individual will develop edema, right? And what is edema? It is extravascular accumulation of the fluid is what is called edema. And next important is the dyslipidemias. So now these plasma proteins are being lost. Once these plasma proteins are being lost, where they have to be synthesized? They have to be synthesized in the liver. So liver synthetic capacity for the proteins increases, but when liver is synthesizing albumin, liver will also synthesize lipoproteins, and because of increase in the synthesis of lipoproteins, these patients will have the hyperlipidemia and as well as the lipiduria. And liver will not only synthesize the lipoproteins, liver will also synthesize the coagulation factors. There is increased synthetic capacity of the liver, and that will result in the hypercoagulability. And apart from albumin, the other proteins which are being lost is the globulin, and globulin is the one which is required for the formation of the immunoglobulins. And once globulins are lost, the immunoglobulin synthesis does not occur, thereby these individuals, they are at increased risk of the infections. And transferrin is also being lost, that will result in iron deficiency anemia, microcytic hypochromic anemia, loss of cholecalciferol binding protein which is required for transportation of vitamin D from the kidney to the intestine. So once your cholecalciferol binding protein is lost, vitamin D cannot reach the intestine, so calcium absorption across the intestine does not occur, and that will result in the hypocalcemia. Next is thyroxine binding globulin is another important protein which is being lost, which will help or which will bind to the thyroid hormone. So once your thyroid binding globulin is lost, that will result in the hypothyroidism. Ceruloplasmin is being lost, that will result in the abnormality related to the copper metabolism, and there will be also hypercoagulability. Hypercoagulability is not only due to increase in the synthesis of the coagulation factors. The hypercoagulability is also due to loss of the natural anticoagulants. What are the natural anticoagulants? That is antithrombin 3, protein C, and as well as protein S being lost. These are the natural anticoagulants, and once these are being lost, that will result in the hypercoagulability. So apart from albumin, these are the other proteins which are being lost. Next, you need to know what are the etiologies that will be causing nephrotic syndrome. The most common systemic disease that will be responsible for the development of nephrotic syndrome is diabetes mellitus. And the most common cause of the nephrotic syndrome in children will be minimal change disease, and the most common cause of nephrotic syndrome in adults will be focal segmental glomerulosclerosis, and the most common cause of nephrotic syndrome in elderly individuals of the age around 60 to 70 years, that will be membranous glomerulonephritis, and the other causes for nephrotic syndrome will be the amyloidosis. Okay, so these are all the various etiologies. Now, out of all these, let me discuss about the diabetes mellitus. Diabetes mellitus will result in what is called diabetic nephropathy, right? But if you take this diabetic nephropathy, it is more common in type 1 diabetics rather than type 2 diabetics. And your diabetes mellitus, as just now I have discussed in CKD, diabetes mellitus is the most common cause for chronic kidney disease. This diabetic nephropathy is more common in those individuals where the HbA1c is more than 7%. And if the HbA1c is more than 7% for 5 years in case of type 1 diabetes mellitus, there will be development of diabetic nephropathy. And next important is, if the HbA1c level is more than 7% for nearly around 20 years in type 2 diabetics, that will be responsible for the development of diabetic nephropathy in case of type 2 diabetics individual. Now, in diabetes mellitus, what are the other renal pathologies apart from the development of diabetic nephropathy? The other renal pathologies are, these patients are at risk of development of renal papillary necrosis, interstitial nephritis, and type 4 renal tubular acidosis, which is the most common form of renal tubular acidosis. And in type 4 renal tubular acidosis, the problem will be either aldosterone deficiency or aldosterone resistance, and that will result in the development of renal tubular acidosis. Then these diabetic patients, they are at increased risk of the contrast induced nephropathy, and they are also at increased risk of NSAID associated renal failure, right? A diabetic patient taking NSAIDs, they are at increased risk of the nephropathy. So these are the other renal pathologies which are observed in patients with the chronic kidney disease. Now coming to the size of the kidneys. So what will happen to the size of these kidneys is, in diabetic patients in early stages, there will be enlargement of the kidney, right? And even there will be increase in the GFR in the early stages. The GFR will be more than 125 ml per minute per 1.73 meter square. And in the later stages, what will happen to the size of the kidneys will be, there will be small sized kidneys, right? And next is, so in the first stage of diabetic nephropathy, you will have increase in the GFR. And later on, as the diabetic nephropathy is progressing, there will be damage to the basement membrane, and the damage to the basement membrane is the one which will result in the microalbuminuria, right? That will result in microalbuminuria. Now, a very important point is, when is that you need to screen for the microalbuminuria in type 1, and when is that you need to screen for microalbuminuria in type 2? So, in type 1 diabetic patients, you need to screen for microalbuminuria after 5 years after diagnosis of type 1 diabetes mellitus, whereas you take in case of type 2 diabetes mellitus, you need to screen for diabetic nephropathy at the time of diagnosis itself, right? And at the time of diagnosis, if microalbuminuria is not there, then you need to do yearly screening of the albumin excretion in type 2 diabetics. Yearly screening should be done if microalbuminuria is not there at the time of diagnosis. Now, when you do a biopsy, what are the glomerular lesions that you will have in case of the diabetic nephropathy is, you have diffuse and nodular glomerulosclerosis. So, you take diffuse. Between diffuse and nodular, the most common will be diffuse glomerulosclerosis, right? The most common will be diffuse glomerulosclerosis, and then compared to nodular. And these patients, what is the earliest manifestation in diffuse glomerulosclerosis will be? That will be thick glomerular basement membrane. And the glomerular lesions or exudative lesions that you will have in these patients will be like capsular drops and as well as the fibrin caps. So this is diffuse glomerulosclerosis. But what is the pathognomic for glomerulosclerosis in case of diabetes mellitus is nodular glomerulosclerosis. And these nodular glomerulosclerosis, these lesions, they are called as the Kimmel-Wilson's lesions, or it is called as intercapillary glomerulosclerosis, right? Or it is called as intercapillary glomerulosclerosis, all right? And that is in nodular. But these patients with diabetes, if the blood glucose levels are more than 500 milligrams per deciliter, the glucose will be absorbed across the proximal convoluted tubule, and the glucose is accumulated in the form of glycogen in the PCT. That is what is called Armani-Epstein change. And how do you treat these patients with diabetic nephropathy? The drug of choice is the ACE inhibitors. What these ACE inhibitors will do is, ACE inhibitors will cause dilatation of the efferent arterioles, thereby reducing the glomerular pressure, and thereby the proteinuria can be reduced. And the drug of choice for controlling the blood glucose in diabetic nephropathy will be insulin. And if the individual says, I cannot take insulin, in patients with diabetic nephropathy, what is the alternative drugs for diabetic management is, linagliptin can be given, right? And then glipizide can be given. Because this linagliptin and glipizide, both of them, they are metabolized and excreted through the liver. They can be safely given in the patients with the chronic renal failure if the patient is not willing to take the insulin. And the antihypertensive drug that you need to take in case of chronic kidney disease with diabetes mellitus will be labetalol. Actually, we are giving ACE inhibitor, but if suppose there is hyperkalemia developed, or if the serum creatinine has increased more than 2 milligrams percentage, then you need to give labetalol. So this is about diabetic nephropathy, which is the most common systemic disease that will be responsible for chronic renal failure. Next important is the minimal change disease. Minimal change disease, this is also called as the nil disease or nil lesion, right? Or the another name for this is, it is also called as the lipoid nephrosis. Okay, now what is the age group at which you see this? This is commonly observed in children and to certain extent the young adults as well. And what are the etiologies? The etiologies, we have certain drugs. The drugs that will cause minimal change disease include the NSAIDs, interferon, lithium. Then we have infections that will be causing the minimal change disease, that includes HIV, infectious mononucleosis, and malignancies that can cause the minimal change disease will be the 𝗠𝐨𝐫𝐞 disease. So these are the etiologies that will be causing minimal change disease. And what will be the presentation of these patients with minimal change disease? Please remember, these patients, they will be presenting with the mother or the parent saying, whenever my child gets up in the morning, he will be having the puffy eyes for prolonged period of time. And I am noticing that there is also weight gain, there is swelling of the face, swelling of the abdomen, swelling of the lower limbs. So I am also observing that there is weight gain, and these are all the features of the fluid overload due to hypoproteinemia or hypoalbuminemia. So these patients will also have the pedal edema. And on examination, you will notice that the fluid will also be there in the serous cavities, that is in the pleural fluid, that is in the pleural effusion. There can be pericardial effusion, and there will also be ascites. So if you measure the abdominal girth will be increased, and the umbilicus is being everted is what you will observe on examination of these patients. And whenever you do workup, one is definitely the blood urea nitrogen and serum creatinine levels are increased, and serum complement levels are being normal, and urine shows the presence of the oval fat bodies, right? So there is lipiduria, that is what you will notice. And next is the biopsy finding. So if you take the biopsy finding, the light microscopy will not show any change. That is the reason why it is called as the nil lesion. Whereas the electron microscopy, you will notice that there is fusion of the podocytes. Okay, and this particular fusion of the podocytes, it is due to loss of membrane polyanion on the podocyte. And what is that membrane polyanion? That is heparan sulfate proteoglycan. Right, heparan sulfate proteoglycan is being lost, and that will be responsible for the fusion of the podocytes, right? And next important is the drug of choice. That is, you need to give steroids. You need to give prednisolone for nearly around 8 weeks. So 4 weeks you give full dose, that is 1 to 1.5 milligrams per kg body weight, and the later 4 weeks you need to taper and stop, right? But whenever you taper and stop, there is a chance that there may be relapse again, and that we call it as the steroid dependent nephrotic syndrome. And in patients with steroid dependent nephrotic syndrome, when you are taking steroids for longer duration of time, the patient can develop Cushing's syndrome. Now in order to avoid the Cushing's, you can give alternative immunosuppressant drug, that is cyclophosphamide can be given. But those patients who are not responding to the steroids, that we call it as steroid resistant nephrotic syndrome, in them you need to give cyclosporin or calcineurin inhibitor, that is tacrolimus can be given. So this is about minimal change disease, which is the most common cause for nephrotic syndrome in children and as well as the young adults. All right, next important form of nephrotic syndrome in adults will be focal segmental glomerulosclerosis, right? That is your focal segmental glomerulosclerosis is the most common cause of nephrotic syndrome in adults. And this focal segmental glomerulosclerosis can be in two forms. One is primary focal segmental glomerulosclerosis, and the other one is secondary focal segmental glomerulosclerosis. Now, you take primary focal segmental glomerulosclerosis, the pathology is within the kidney, and it is mainly because of the gene mutation. And what are the genes that is being mutated is APOL1 gene is being mutated. There can be mutation of the several podocyte proteins, where there be mutation of the type 4 collagen mutation can be there, and even increased circulating permeability factor is also responsible for primary FSGS. These are the three etiologies for primary FSGS. Whereas secondary FSGS, you have a known etiology like obesity, HIV, drugs like the heroin addiction, bisphosphonates, right? And so obesity, hypertension, chronic urinary reflux, HIV infection, analgesic abuse, bisphosphonates, they are the one which will be responsible for secondary FSGS. And usually in nephrotic syndrome, you don't have hematuria, but FSGS is one particular etiology where you will have the presence of the hematuria, and these patients will also have hypertension, and that will be responsible for headache. And the type of proteinuria that you will have is non-selective proteinuria, whereas in minimal change disease it is selective proteinuria. Albumin is being lost, whereas here along with albumin all other proteins are being lost, that is globulin and all other proteins are lost, and that we call it as non-selective proteinuria. And how is the course of the disease? Almost in 50% of the individuals, they go into a state of renal failure in next 6 to 8 years, and on examination you will notice that there is hypertension, and because of hypertension there will be development of the headache, right? And when you do workup in these patients, the blood and urine analysis, the serum creatinine and as well as urea is being elevated, and when you do a urine analysis you will notice that along with the proteins you have the RBC and as well as the RBC cast, and the number of RBCs will definitely be more than 3 RBCs, and along with that RBC cast also will be there. But the investigation of choice will be the biopsy, and you have to take the biopsy from corticomedullary junction, and if you take the superficial biopsy there is a high chance that the diagnosis can be missed. And whenever you take the biopsy from the deep, that is corticomedullary junction, in the light microscopy you will notice that it is only the part of the glomerulus that is being involved, or it is only the part of the glomerulus, and only few glomeruli will undergo sclerosis or the fibrosis. And in electron microscopy you will notice that there is hyaline deposits, and your focal segmental glomerulosclerosis is the disease where there is damage to the podocytes. So you will notice that there is podocyte foot process being effaced. Same, even in minimal change disease also you have effacement of the podocytes. But here along with that you will also have detachment of the podocytes, and you will also notice that there is vacuolization of the podocytes. And how do you treat these patients? In case of primary FSGS you need to give immunosuppressant drugs, and that is the prednisolone. And in those individuals who are not responding to the steroids, so in steroid resistant and steroid intolerant cases you need to give calcineurin inhibitors, and mycophenolate mofetil should be given. Whereas in case of the secondary FSGS you need to treat the underlying cause, and supportive treatment is required, and that will be in the form of the diuretics. And the diuretics are the one which will clear the edema and as well as the fluid overload. ACE inhibitors are very much useful to control the proteinuria by decreasing the intraglomerular pressure, and what these ACE inhibitors will cause efferent arteriolar dilatation. And for hypertension you need to give labetalol. Statins have to be given for the those individuals who are having dyslipidemia. So this is about focal segmental glomerulosclerosis, which is the most common cause of nephrotic syndrome in the adults. Next is, what is the most common cause for nephrotic syndrome in elderly individuals? So in elderly individuals it is membranous glomerulonephritis, and please remember this membranous glomerulonephritis, the problem is there will be accumulation of immune complexes in the subepithelial portion, right? In subepithelial portion of the glomerulus there will be immune complexes, right? And subepithelial portion of the glomerular capillary. And for the development of membranous glomerulonephritis, we have two forms of membranous glomerulonephritis: primary and secondary membranous glomerulonephritis. Now, what is this primary membranous glomerulonephritis? Primary, it is due to immune complex deposition. What does this immune complex contain? One antigen, the other one is antibody. What is the antigen in this immune complex? The antigen in this immune complex will be phospholipase A2 receptor on the podocyte. And against this particular receptor, which is acting as an antigen, the antibody will come and bind, and that will result in the formation of the immune complex, and that will be deposited in the subepithelial portion of the glomerular capillary wall. Secondary membranous glomerulonephritis, it is secondary to certain malignancies. What are the malignancies? Carcinoma of the breast, carcinoma of the colon, carcinoma of the esophagus, carcinoma of the stomach, carcinoma of the lung. So these are the malignancies that will contribute to secondary membranous glomerulonephritis, and the infections that will be causing membranous glomerulonephritis will be hepatitis B and hepatitis C, leprosy, syphilis, malaria, schistosomiasis, filariasis, and hydatid disease. These are the infections that will be contributing to secondary membranous glomerulonephritis. And autoimmune diseases that include systemic lupus erythematosus, rheumatoid arthritis, Sjogren's syndrome, Graves' disease, Hashimoto's thyroiditis, and primary biliary cirrhosis. These are the autoimmune conditions. Then what are the drugs that will be causing the membranous glomerulonephritis? Are gold salts, penicillamine, captopril, NSAID, probenecid. These are the drugs that will be contributing to secondary membranous glomerulonephritis. Then there are certain parameters to tell that the individual has a poor outcome in membranous glomerulonephritis. What will be that? If there is concomitant tubulointerstitial fibrosis, or in males the outcome of membranous glomerulonephritis is not good, and if there is renal failure causing elevated serum creatinine, the outcome of the patient will not be good. Hypertension and as well as proteinuria more than 10 grams per day. So these are the points to tell that the outcome of the individual is very, very poor. What will be the clinical features? These patients, they will have edema, right? And why is that? That is due to proteinuria. They will have frothy urine because the protein is getting excreted in the urine. And these patients with membranous glomerulonephritis, almost 40 to 50% of patients, they are at increased risk of renal vein thrombosis. And this particular renal vein thrombosis is what is responsible for post-renal type of acute kidney injury. Right, post-renal type of acute kidney injury. And these patients with renal vein thrombosis, you will notice that there is enlargement of the kidney, and once there is enlargement of the kidney, these patients will present with the loin pain. And how do you treat renal vein thrombosis is you need to give the heparin. Right, you need to give heparin, right? And what will be the examination findings? These patients will have hypertension, and because of the fluid overload, that can cause the headache, and they will have edema, and that is due to proteinuria. And next is, upon the workup, you will notice that blood urea nitrogen and serum creatinine is being elevated, and biopsy is the investigation of choice. Light microscopy will show you that there is thickening of the basement membrane, and that is due to subepithelial accumulation of the immune complexes. And the electron microscopy will show you that is subepithelial deposition, and this subepithelial deposits can be made out by silver methenamine stain. And silver methenamine stain with electron microscopy, you will notice that there is spike and dome pattern in case of membranous glomerulonephritis. And immunofluorescent microscopy will show you that there is IgG and as well as C3 upon staining. And treatment is, in primary, you need to give immunosuppressive drugs in order to prevent the immune complex formation, and this includes prednisolone and as well as cyclophosphamide, or rituximab can be given, or prednisolone and cyclosporine can be given. Whereas for secondary form of membranous glomerulonephritis, that is secondary to malignancy, secondary to infection, secondary to autoimmune disease, secondary to drugs, you need to treat the underlying cause. It is only for primary you need to give the immunosuppressant drugs. So this is about your membranous glomerulonephritis. So this completes the discussion of your nephrotic syndrome. So the next important topic for the discussion is the nephritic syndrome. So nephritic syndrome, the important point is the proteinuria that you will have is subnephrotic proteinuria, that is less than 3 grams per 24 hours is the proteinuria that you will have in case of nephritic syndrome. And because of the proteinuria, the oncotic pressure will be reduced, and that will cause the fluid overload, resulting in the edema, and there will also be development of hypertension. And they will also have oliguria, where the urine output will be less than 400 ml per 24 hours. Right, less than 400 ml per 24 hours. And these individuals can also progress to a state of anuria. Right, anuria is that where the urine output will be less than 100 ml per 24 hours. Right, and these patients, they will have a nephritic urinary sediment. What does this nephritic urinary sediment contain? The nephritic urinary sediment contain WBC. There can be presence of the WBC cast, and there will also be presence of the RBC and inflammatory cells. And we have a terminology called proliferative glomerulonephritis. So proliferative glomerulonephritis is that where the patient will have the two forms under the proliferative glomerulonephritis. If the individual develops acute onset renal failure, that will be the nephritic syndrome. But if the patient develops subacute renal failure, that will be rapidly progressive glomerulonephritis. Okay, and in case of the rapidly progressive glomerulonephritis, what is the very important parameter in the biopsy is there should be presence of crescents. Now what do you understand by these crescents? Crescents are nothing but half moon shaped collection of, right, half moon shaped collection of the inflammatory cells. Right, half moon shaped collection of the inflammatory cells, and these inflammatory cells are macrophages and then the epithelial cells. Right, then the epithelial cells. Now what are the etiologies that will be causing your nephritic syndrome or rapidly progressive glomerulonephritis is, we have the disorders where there is immune complex deposition that you observe in case of the infective endocarditis and post-streptococcal glomerulonephritis resulting in nephritic syndrome. Then multi-system diseases which will be causing the nephritic syndrome will be Buerger's disease, which is nothing but your IgA nephropathy, and we have small vessel vasculitis, that is Wegener's granulomatosis and 𝐒𝐮𝐬𝐜𝐫𝐢𝐛𝐞 purpura, then medium vessel vasculitis, that is polyarteritis nodosa, and the other multi-system disease will be Goodpasture syndrome. So these are the multi-system diseases that will be contributing to the development of the nephritic syndrome. Next is the drugs. The drugs that will be causing nephritic syndrome will be penicillamine. So these are all the etiologies that will be contributing to the development of nephritic syndrome or less severe form, that is rapidly progressive glomerulonephritis. Now you take this post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, it is secondary to infection, and that we call it as the post-infectious glomerulonephritis. And this post-infectious glomerulonephritis, it can be secondary to streptococcal infection and as well as the staphylococcal infection. But the most common will be post-streptococcal glomerulonephritis rather than the staphylococcal infection. And this post-streptococcal glomerulonephritis, it is caused secondary to group A beta hemolytic streptococcal throat infection or streptococcal skin infection. Streptococcal throat infection is more common in the winter, and streptococcal skin infection, it is more common in the summer. And the latent period for throat infection will be around 1 to 3 weeks, and the serotypes are M type 1, 2, 3, 4, 25 and as well as 12. But the most common serotype will be serotype 12. And secondary to skin infection, it is more common in summer, that we call it as impetigo, whereas throat infection we call it as pharyngitis. And the latent period after the skin infection for the development of post-streptococcal glomerulonephritis is around 3 to 6 weeks, and the serotypes are 47, 49, 55, 2, 60 and as well as 57. But the most common serotype will be 49. The age group you see this post-streptococcal glomerulonephritis is usually 5 to 15 years of age. That is very common in children. And the clinical features is that the child will present by complaining the presence of the cola colored urine, and these patients will have hypertension and the development of the pulmonary edema as well. And upon urine analysis, you will notice that there is RBC and RBC cast, and there will be also dysmorphic RBC because of the glomerular abnormality, and these patients will also develop the proteinuria as well, but the proteinuria will be around 3 grams per 24 hours. And what will happen to serum complement levels? There will be transient reduction of the serum complement levels for nearly around 1 to 2 weeks, and after that the serum complement level will return back to normal after 4 to 8 weeks, right? And the serology is very important. So serology, if you take after the throat infection, the antibodies that can be formed by the serotype is the ASO, anti-DNase-B, anti-NAD and anti-hyaluronidase. But after the skin infection, which is nothing but the impetigo, that particular serotypes will be producing the serologies, that is anti-DNase and as well as anti-hyaluronidase only, right? Then the investigation of choice will be biopsy, but usually we don't do biopsy in post-streptococcal glomerulonephritis because the presentation is the one which will give you the diagnosis. Children, throat infection or skin infection in past few weeks, now presenting with cola colored urine, very much suggestive of post-streptococcal glomerulonephritis. But if the serum complement levels are persistently reduced, it is not your post-streptococcal glomerulonephritis, it is suggestive of membranoproliferative glomerulonephritis, that is MPGN, right? And only in that scenario, if the serum complement levels are persistently reduced, or if the urea and creatinine are like gradually increasing, progressing, then you need to do biopsy to rule out the post-streptococcal glomerulonephritis, right? And next important is the electron microscopy. The electron microscopy will show you the presence of humps. First is light microscopy. Light microscopy will show you that there is diffuse proliferative glomerulonephritis and there will be infiltration of the neutrophils. And electron microscopy will show you the presence of the humps, and that is due to subepithelial accumulation. And immunofluorescent microscopy will show you that there is IgG and as well as C3, and in the immunofluorescent microscopy you will have this starry sky appearance. That is very, very important. Next is the treatment. As such, there is no specific treatment, there is no role of antibiotics because the infection is not the present infection, it is the past infection. For hypertension, you need to give antihypertensives like labetalol or ACE inhibitors can be given. For pulmonary edema, you need to give the diuretics, which will clear the pulmonary edema and as well as the pedal edema. And overall, how is the prognosis in patients with post-streptococcal glomerulonephritis? They have good prognosis and recurrence is rare, right? Recurrence is rare, okay? And the type of hypersensitivity reaction that you will have is a type 3 hypersensitivity reaction because you have accumulation of immune complexes within the glomerulus. So this is what is your post-streptococcal glomerulonephritis. So After having discussed about the post-streptococcal glomerulonephritis, the next important topic in the nephritic syndrome is the IgA nephropathy, which is also called as the 𝗑𝐺𝐻 disease. So please remember, you should not get confused with the IgA vasculitis. IgA vasculitis is the 𝐒𝐮𝐬𝐜𝐫𝐢𝐻𝐿𝐼𝐻 Purpura, and at the same time you should not get confused with the another important terminology, that is BEURGRS, 𝗑𝐺𝐻. So this is thromboangiitis obliterans, which is a medium vessel vasculitis. And another name for this IgA nephropathy or 𝗑𝐺𝐻 disease, it is also called as mesangial-proliferative glomerulonephritis, because there is excessive proliferation of the mesangial cells. And here the very important point is the glomerular capillary, right? The glomerular capillaries, they are absolutely normal. Right, glomerular capillaries, they are absolutely normal. That is what you observe in case of IgA nephropathy or the 𝗑𝐺𝐻 disease. Now, what is the etiology in IgA nephropathy or 𝗑𝐺𝐻 disease is, it is like the infection 2 to 4 days back. So 2 to 4 days back, the history of upper respiratory tract infection or gastrointestinal infection or the urinary tract infection is the one which will predispose to the development of IgA nephropathy or 𝗑𝐺𝐻 disease. And the clinical features, these patients, they will have recurrent microscopic hematuria. This is a very important point of difference from the post-streptococcal glomerulonephritis. In post-streptococcal glomerulonephritis, you don't have the recurrence. The recurrence is very rare, but here the recurrence is very common. And the blood pressure and as well as urine output of these individuals will remain normal because the glomerular capillaries are being normal. Whereas in post-streptococcal glomerulonephritis, we have discussed that the individual will develop the hypertension. And recurrence is high, and definitely the investigation of choice will be the biopsy, where you will notice that there is mesangial proliferation. That is what you will observe on the light microscopy. And in the electron microscopy, you will notice that there is mesangial and paramesangial deposits. And in the fluorescent microscopy, you will notice that there is presence of IgA in the mesangium, right? So that is what is the biopsy finding. And what will happen to the serum complement levels? The serum complement, so what is the 𝐶𝐼𝐻 for diagnosis? The 𝐶𝐼𝐻 for diagnosis is IgA in the mesangium is the 𝐶𝐼𝐻 for diagnosis. Okay, that means the presence of IgA in the mesangium is mandatory, okay, for the diagnosis of the IgA nephropathy. Whereas serum complement levels, and serum IgA levels, they remain normal. So there is no role of serum IgA in the diagnosis of IgA nephropathy, and even serum complement levels also will remain normal. And 20 to 40% of the individuals, they progress to the development of the end stage renal disease. This is when the individual will have the development of the hypertension, they'll have the features of the fluid overload. And how do you treat these patients? You need to give steroids and cyclophosphamide for nearly around 3 months. And this will be followed by supplementation of the azathioprine for nearly around 2 years. So this is about the IgA nephropathy or the 𝗑𝐺𝐻 disease, the quick revision. So to differentiate between post-streptococcal glomerulonephritis and IgA nephropathy, remember, post-streptococcal glomerulonephritis, these patients, they will have the past history of streptococcal throat or skin infection 1 week to 3 weeks back, or it may be even 3 to 6 weeks back as a latent period also. Whereas in IgA nephropathy, the latent period is very short. That is only 2 to 4 days after upper respiratory tract infection, there will be development of your IgA nephropathy. Serum complement levels, they are transiently reduced, and then it will return back to normal by 4 to 8 weeks in case of PSGN. But serum complement levels will remain normal in IgA nephropathy. And what about the recurrence? Recurrence is rare in post-streptococcal glomerulonephritis, whereas in IgA nephropathy, the recurrence is common. Then what will happen to the ASO titer? The ASO titer in case of post-streptococcal glomerulonephritis, it is increased, whereas in IgA nephropathy, the ASO titer will remain normal. So these are the differences between PSGN and as well as the IgA nephropathy. And the next important form of the nephritic syndrome or the etiology causing nephritic syndrome will be the Gscht syndrome. So let me tell you, this Gscht syndrome, it is an autoimmune disease. Now this being an autoimmune, this is more common in males rather than females. And so it is antibody mediated. So what type of hypersensitivity reaction is this? It is a type 2 hypersensitivity reaction. and the organs which are affected in Goodpasset syndrome will be kidney and as well as the lungs. These are the two important organs which are affected in case of the Goodpasset syndrome. And what is the antibodies formed against? Please remember, the antibodies are formed against alpha 3 chain of type 4 collagen, right? So GPS, Goodpasset syndrome. So it's a 3-letter word. Please remember, alpha 3 chain of type 4 collagen. Whereas in case of the Alports, right, it is alpha 5 chain. So this S in Alports is looking like 5. So please remember, Alports, it is alpha 5 chain of type 4 collagen that is being defective. And because the lungs and as well as kidneys are being affected, these patients, the presentation will be in the form of hematuria and as well as the hemoptysis. Serology, if you see, the anti-glomerular basement membrane antibodies will be there, or anti-alveolar basement membrane antibodies will be there, but the sensitivity of these antibodies, it is just only 90%. That is the reason why the investigation of choice will be the biopsy. Now, what does the biopsy show? It shows the presence of diffuse proliferative glomerulonephritis, and there will also be presence of the crescents. What is crescents? It is the half moon shaped collection of the inflammatory cells where you have macrophages and as well as the epithelial cells. Whereas the immunofluorescent microscopy will show you the presence of the linear deposits of the antibodies. Right, linear deposits of the antibodies. And what does the lung show? Lung shows the presence of focal alveolar necrosis. There will be intraalveolar hemorrhage, but the necrosis that you will have is the focal alveolar necrosis. And whenever you do a chest X-ray of these individuals, you will notice that there is bilateral infiltrates, alveolar infiltrates will be there. Then how do you treat these patients? The first line treatment is you need to do plasmapheresis, and the plasmapheresis will remove the existing antibodies. Then you need to give the immunosuppressants to prevent the new antibody formation. And what are these immunosuppressants? That includes steroids and as well as azathioprine should be given in order to suppress the new antibody formation, or you need to give steroids and as well as cyclophosphamide to suppress the new antibody formation, right? And in refractory cases, what is that you need to do is rituximab is what you need to give if the patient is not responding to corticosteroid and cyclophosphamide. Then there are certain parameters to tell you that there is poor prognosis in patients with the Goodpasset syndrome, and these poor prognostic features include oliguric acute kidney injury. So oliguric acute kidney injury is a poor prognostic factor. Okay, so this is about the Goodpasset syndrome. Now let me discuss about the Alport syndrome, where the abnormality is in the alpha 5 chain of type 4 collagen. And this alpha 5 chain of type 4 collagen is present in the kidney, it is present in the eyes, and it is also present in the ears. Now, what will be the renal manifestations these individuals will have is, the renal manifestations will be in the form of the hematuria. So hematuria, it is the earliest feature in case of the Alport syndrome, right? And what are the other features apart from the hematuria? These patients will have proteinuria, that is what you will examine in the urine analysis. Then what will be the abnormality in the ear? So please remember, most common extrarenal manifestation, the most common extrarenal manifestation will be in the form of the sensory neural hearing loss. And ophthalmic manifestation is that there will be increase in the anterior curvature of the lens, and that we call it as the anterior lenticonus. Right, this we call it as anterior lenticonus, and this anterior lenticonus will be bilateral. So bilateral anterior lenticonus will be there, and there will be this increased anterior curvature of the lens. There will be erosions, so that will result in the corneal erosions and as well as the cataract. Okay, so these are the features that you will have in case of the Alport syndrome, right? Now, after having discussed about the nephritic syndrome, then let me take up the discussion of the polycystic kidney disease. So polycystic kidney disease, like, it is inherited in two ways. One is autosomal recessive and the other one is autosomal dominant. But which is more common? The more common is autosomal dominant type of inheritance, which is observed in adults. Whereas autosomal recessive type of inheritance, it is observed in children. Right, in children you will have autosomal recessive type of inheritance. And in autosomal recessive type of inheritance, what is the gene that is being mutated? That is PKHD1 gene, and which is present on chromosome number 6. Now let me take up the discussion of autosomal dominant type of polycystic kidney disease which is observed in adults. These patients with autosomal dominant type of polycystic kidney disease, they are asymptomatic until 3rd to 4th decade of life. So at around 30 to 40 years of age, these patients will present with the clinical manifestations in the form of loin pain, and by the age of 5th to 6th decade, they land up into the end stage renal failure. Now, in order to develop autosomal dominant polycystic kidney disease, you need to be aware of gene mutations and chromosomal numbers. The gene that is being mutated is the PKD1 and as well as PKD2 genes are being mutated, which are present on chromosome number 16 and as well as 4. And if you take the pathology in case of polycystic kidney disease, you will notice that there is enlarged kidneys, and in this enlarged kidneys, you have the presence of cysts, and these cysts, they are distributed throughout the cortex and as well as the medulla, and that is what is giving an appearance of the enlarged kidneys. So once the kidneys are being enlarged, the fascia of the gerota which is present around the kidney, that is being stretched, and that will result in the development of the loin pain. And these cysts, there is high chance of infection, and if these cysts are being infected, these patients, they are at increased risk of the acute abdominal pain. And these patients, they are having the uric acid stones because of decreased uric acid excretion, which will accumulate in the kidney, resulting in the uric acid stones. And some of these individuals will also have the hematuria. And on examination, you will have hypertension because these individuals may land up in chronic renal failure causing fluid overload, or these particular cysts will be compressing the glomeruli, that will result in decrease in GFR, causes activation of RAS, and that will result in the development of the hypertension. And the hypertension is the cause of death in these individuals, and by almost 6th decade, they will land up in end-stage renal disease. And you also need to know the extrarenal manifestations. The cysts are not just present only in the kidney, the cysts are also present outside the kidney. The most common extrarenal site where you have the presence of the cyst is within the liver, so you will have the presence of the liver cyst. Next important point is the berry aneurysms. So these patients, there will be aneurysms originating from circle of Willis, and that is called berry aneurysms. Whenever these are ruptured, the individual will develop subarachnoid hemorrhage. And the gastrointestinal manifestation will be in the form of colonic diverticulosis, right? And when you do a barium enema, right, or when you do a barium studies, what is that you will notice in case of colonic diverticulosis is, in the imaging, you will notice that there is a sawtoothed appearance. And the cardiovascular system manifestation will be in the form of mitral valve prolapse, where the individual will have a mid-systolic click with late systolic murmur. So what is the first line investigation in these patients is, you need to do ultrasound abdomen. And the number of cysts completely depends upon the age of the individual. For suppose, if the age of the individual is around 15 to 29 years, there should be 2 cysts, either in each kidney or both the kidneys together, there should be 2 cysts if the age of the individual is 15 to 29 years, right? And if suppose, if the age of the individual is around 30 to 59 years, then there should be presence of 2 cysts in each kidney. And then followed by that, if the age of the individual is more than 60 years, then there should be number of 4 cysts in each kidney. So that is about the first line investigation. Then what is the investigation of choice is the CT of the abdomen will confirm the diagnosis and as well as the number of cysts as well. And the treatment for the hypertension, you need to give ACE inhibitors, that is because of the activation of RAS. And these cysts are at increased risk of the infection. There is acute abdominal pain and there can be urinary tract infection. Now the antibiotic that you should give, it should be a lipid soluble antibiotic that should penetrate the cysts. And what are these lipid soluble antibiotics? These lipid soluble antibiotics that includes quinolones. Quinolones are the lipid soluble antibiotics, right? Then next is the tramadol. So if you take this particular tramadol, it is useful for reducing the pain which has occurred due to the enlargement of the kidney. And followed by that, you need to give sirolimus. What is this particular sirolimus? Sirolimus is the drug which will prevent the progression of the disease in case of polycystic kidney disease. So this is about your polycystic kidney disease. Done? Now, so after doing the quick revision of the polycystic kidney disease, let me just show you the image of this polycystic kidney disease. So these are the presence of the cysts, and these cysts, they are completely filled with the straw colored fluid. That is what you will observe in case of polycystic kidney disease. Now, after having discussed about the polycystic kidney disease, the last topic for the discussion will be the renal tubular acidosis. Now, if you take this renal tubular acidosis, it is hyperchloremic normal anion gap metabolic acidosis. Now, what do you understand by this word normal anion gap? The normal anion gap, it is around 8 to 12 milliequivalents per liter. That is a normal anion gap. And hyperchloremic. Why is that there is a hyperchloremia? Because these patients, there is loss of bicarbonate, which is a negatively charged ion. Now, the kidney, in order to compensate another negatively charged ion in our body, because there is loss of bicarbonate, the kidneys will try to reabsorb the chloride, which is a negatively charged substance. So, that will result in the hyperchloremic normal anion gap metabolic acidosis. And mainly we have three types, type 1, type 2 and as well as type 4 renal tubular acidosis. And if you take the pathology of these, in type 1 renal tubular acidosis, the pathology is in the distal tubule where there is failure of secretion of the H+. Right, where there is failure of secretion of the H+ ion. So thereby how will be the urine? Now the urine will be completely an alkaline urine where the pH of the urine will be more than 5.5. Whereas in case of type 2 renal tubular acidosis, which is also called as Fanconi syndrome, the pathology will be in the proximal convoluted tubule where the absorption of the bicarbonate does not occur. So bicarbonate absorption does not occur at the level of proximal convoluted tubule. Now, when we are using this term Fanconi syndrome, in the PCT, it is not just only bicarbonate not being absorbed. There are many other substances which will not be absorbed in case of the type 2 renal tubular acidosis. Now, what are the other substances which are not absorbed is glucose is not absorbed, resulting in glucosuria. Uric acid is not absorbed, resulting in the uricosauria. Right, and even the phosphate is not absorbed, resulting in the phosphaturia. Bicarbonate is not absorbed, resulting in bicarbonaturia. That is what you will observe in case of type 2 renal tubular acidosis. Whereas in case of the type 4 renal tubular acidosis, it is not exactly the pathology of the tubule. There is either absence of the aldosterone or there is aldosterone resistance. What this aldosterone do? Aldosterone is the one which will cause secretion of the H+ and it will cause the excretion of the H+ ion. So because of the aldosterone resistance or aldosterone absent, the H+ ion will not be secreted into the tubule. Thereby, the H+ ion will retain in the body, resulting in acidosis, right? And here also, if you take, the H+ ion is not getting secreted. So thereby, what will happen to the urinary pH? That will be more than 5.5. It is only in case of type 2 renal tubular acidosis where the urinary pH will be less than 5.5, whereas in all others, the urinary pH will be more than 5.5. Then if you take the etiology, we have some systemic causes and as well as the drugs. And what are the systemic causes for type 1 renal tubular acidosis is sickle cell, Jögren's, Wilson's and myeloma. And the drugs that will be causing your type 1 will be lithium and as well as the amphotericin B. So similarly in type 2, if you take Jögren's, cystinosis and Wilson's, these are the systemic causes. And the drugs that will be causing your type 2 renal tubular acidosis will be acetazolamide, which is the carbonic anhydrase inhibitor, topiramate, which is a newer anti-epileptic drug, and tenofovir is the antiviral drug which can be given both in the treatment of HIV and as well as the hepatitis B virus. That can cause type 2 renal tubular acidosis. And type 4 renal tubular acidosis, systemic causes will be diabetes mellitus, HIV, sickle cell disease and then the Addison's disease. So these are the systemic causes. Then what are the drugs? So basically the drugs should decrease the aldosterone synthesis or there should be an aldosterone resistance, and that is achieved by the ACE inhibitors or angiotensin receptor blockers, next spironolactone, and next is the trimethoprim sulfamethoxazole. So mainly trimethoprim is the one which will be causing the aldosterone resistance or absence of the aldosterone. So this is about the etiologies which will be causing your renal tubular acidosis. And what will happen to the potassium level in case of renal tubular acidosis? Except in case of type 4, there will be hypokalemia in both. Whereas in type 4, you will have the hyperkalemia where there will be increase in the potassium level. Now, what is the loss of bicarbonate? Percentage loss of bicarbonate, if you see, in case of type 2 renal tubular acidosis, there is maximum loss of bicarbonate. And the bicarbonate that is being lost is more than 15% in case of type 2. Whereas in type 1 and type 4, less than 10% of the bicarbonate is being lost. And if you take the renal stone formation, yes, in case of type 1, you have the calcium stone formation. Right, you have calcium stone formation in type 1 renal tubular acidosis, whereas in type 2 and type 4, the renal stone formation is absent. Then we were discussing about the urinary pH. Only in case of your type 2, the urinary pH will be, right, so this here I have written exactly the reverse. Right, so urinary pH in case of type 1 and as well as type 4, it will be more than 5.5, whereas urinary pH in case of the type 2 will be less than 5.5. That is what you will notice in case of type 2 renal tubular acidosis. And daily acid excretion, it is normal in case of type 2 but low in case of type 1 and type 4. Urinary anion gap is positive in all. Then coming to the treatment, in case of type 1 you need to give oral bicarbonate, and how much will be that dose? 1 to 2 milliequivalents per kg is what you need to give in case of type 1. But whereas in type 2, the problem itself is the bicarbonate loss, so you need to give high dose of bicarbonate, that is around 10 to 15 milliequivalents per liter of the soda bicarbonate should be given, and along with that the potassium supplementation should be given both in type 1 and as well as type 2. Whereas in type 4, the drug of choice will be fludrocortisone, that is acting as an aldosterone analog, but these patients will also be requiring the oral bicarbonate in the low dose, that is around 1 to 2 milliequivalents per kg is what you need to give. And the diet that you should give is potassium restricted diet that you need to give in patients with type 4 renal tubular acidosis because there is hyperkalemia. So this is about the quick revision related to renal tubular acidosis. Thank you very much.